My name is Solange Durand, and I'm here at Cochrane, South Africa. I'd like to welcome everybody who's attending the webinar. The theme for today is the GRADE Evidence to Decision Framework, and our facilitator is Dr. Tamara Credo. Dr. Credo is a senior specialist scientist at Cochrane, South Africa, based here at the South African Medical Research Council. She's a medical doctor with a specialist qualification in clinical pharmacology and has worked for many years in the field of evidence-informed healthcare, in particular evidence synthesis. The focus of her research includes exploring the South African primary care guideline landscape and developing partnerships for enhancing guideline activities in South Africa. Additional areas of work include supporting capacity development initiatives for evidence-based healthcare in South Africa and in the African region through the work of Cochrane Africa Network, and optimizing communication of evidence to relevant stakeholders to inform healthcare decision-making. Before I hand over to Tamara, I'd like to just do a bit of housekeeping. So please keep yourselves muted by clicking on the little microphone button. Otherwise, it causes interference. You will be able to ask questions along the way, or Tamara will say whether you can ask questions along the way or whether we will wait until the end. But when the moment comes, you can ask questions by either sending a message in a chat box or by unmuting yourself and asking the question. Please note we are recording the webinar, and the recording will be available at Cochrane South Africa's website afterwards. And we will also share the slides with all participants after the webinar. Thanks everyone, and I'll hand over to Tamara.
Thanks, Solange. That's great. Thank you for the warm welcome. And I hope everyone can hear me. As Solange said, my name is Tamara. I'm based at Cochrane, South Africa. And I'm, to be very honest with all of you, I'm very excited, but I'm also a bit nervous because it's my first webinar that I'm facilitating. And I am hoping to have some discussion and conversation with you all along the way. So I am going to stop to ask you some questions and see how that works. And I'd also ask you to drop a line to Solange in the chat box if you want to ask a question. So I think people will have to do it via the chat box, and then we'll try and make sure that that's all captured. But I'm really looking forward to sharing a little bit that I know on this. And so if I can just ask you all to mute yourselves as we kickstart and yeah, see how we go. So today I thought I would focus a little bit on a topic that I find very interesting, which is around decision-making in guidelines, and in particular looking at the evidence to decision frameworks that groups like GRADE have been developing to try and unpack the process and to create transparency in how it's done. So as a first slide, just to my disclosures. So I'm based at Cochrane, South Africa. I'm also involved with Cochrane Africa and the Pan-African Clinical Trial Registry. Hot off the press is that myself and Taryn Young from the Center for Evidence-Based Healthcare at Stellenbosch, amongst a number of other founding people, have recently been awarded a GRADE network, approval to have a GRADE network in South Africa, and so there'll be more news on that soon. I'm also involved with the National Department of Health Essential Medicine List, and related to this particular presentation is a project that DFID is kindly funding called Read It, where there's a big emphasis on relevant policies and guidelines. But I have no direct financial conflicts of interest with respect to this content. A number of people have provided some input into the presentation or have shared their slides, so I lean on many great people, but I'm happy to share what I've learned. So just to start off with, so when I thought through the session, I thought what I would discuss is outlining the purpose of what an evidence to decision framework is all about, list and explain the different parts of an evidence to decision framework, And then if we can manage, we're going to discuss a bit about using evidence to decision frameworks in our own contexts. So let's see how we go. So the first thing I want to do is check out how this works. So I have made all of you able to draw on my slides, I think. So I want to ask you the question, which of the following best describes you? And can you write either a cross or a tick in the box that pertains to you? So you should all have pens that if you have, for those that are connected via the web, you should be able to write on the screen. Let's see if it works. So please mark on the screen where you think you best fit. Very exciting to see this. Those that are connected via the web unfortunately can't do it, but I'm trying to connect all the others that are connected in other ways, especially those that have just joined. Otherwise, Solange, maybe you can keep an eye out for any others. Okay. Cool. Great. Okay. So I'm going to try and use this throughout the presentation, but I just encourage you, don't write on my other slides until I ask you to. But so it's interesting to see that on the line now today we have mostly researchers, people who some of us wear many hats, so researchers, practitioners, and some students. So thanks for sharing that. My next question is, if I can change the slide. Oh, hang on, I have to delete the previous one. Is who of you have been involved with guideline development? So mark in the box that best suits you. Okay. I like the squiggle. Thank you. So some have been involved, others not so much. So most of us tend to be, particularly as researchers, and I would class myself there as well, we tend to be on the outskirts of the actual guideline development process. So I'm going to switch over now. I'm going to clear that and move to the next slide. If I can, let's see. And who of those people who mentioned that they may have been involved with guidelines has used an evidence to decision framework? Could you mark on, have any of you used evidence to decision framework? So some have. Okay, fantastic. So what I would just ask is that along the line and perhaps further towards the end of the conversation, we might ask for examples and experiences that people have with guidelines in that respect. Thanks so much for sharing. We switch back. So I just wanted to talk through the principles of guideline development and talk about an approach that is a traditional approach to guideline development. I'm not sure if any of you would have come across the GOBSAT approach for guidelines. But this is my understanding and from the literature of how guidelines were developed even hundreds of years ago up to not so long ago, the past 20 or so years. And GOBSAT stands for the good old boys sat around a table. And I guess many of us could see why that state of developing guidelines is no longer the way forward. There's a lot of opaqueness when you have a group of people, perhaps with a certain worldview, that sit around a table and come up with guidelines. But how do we progress from a GOBSAT guideline to where we are now? And maybe a good place to start is for us to define what is a guideline so that we're all on the same page about what this means. So from certain guidelines or from guidance on guidelines, guidelines are recommendations intended to assist providers, that is generally practitioners or clinicians, and the recipients of healthcare and other stakeholders to make informed decisions. WHO defines guidelines as systematically developed evidence-based statements which assist providers, recipients, and other stakeholders to make these informed decisions about appropriate healthcare interventions. Health interventions are defined broadly to include not only clinical procedures, but also public health actions. So guidelines may operate at many levels, at the individual level, at the population level, at the public health level, including issues of coverage issues such as vaccines and programmatic level decisions. And increasingly with this definition, where you see it starts with systematically developed evidence-based statements, so I think increasingly we're seeing the use of evidence-based and the need for systematic reviews in the development of guidelines. And I guess that's why people at a Cochrane Center might be quite interested in this particular field, is how we create the best kind of guidance to assist providers and recipients. So I guess the other thing to say, any of us, we make decisions, we probably make hundreds of decisions every day, from what color socks to put on and what to have for breakfast. And we have all the machinations going on in our mind about how we make these decisions. But the important thing to note in terms of the small decisions, like what color socks to wear, and the big decisions, as in which medicine to prescribe for a patient or which interventions to recommend for a population, is that the decision-making process is generally not linear. And when you have an individual making a decision, like I make a decision about something, as opposed to a whole panel or group of people making decision, it becomes more and more complex. And so I don't think there's any particular direction that people could say decision making takes, but except to agree that it's generally not linear. So you can have divergent decisions, cyclical, convergent, iterative, opposing, parallel, and all of this is to come to some recommendation or decision ultimately. So why bother with GRADE evidence to decision frameworks? And I'm not recapping today on GRADE and how that fits in, but rather on the frameworks that GRADE has developed to support guideline panels. Is that when a guideline group sits together and they consider all of the problems and the options and what is the issue that they need to address, and then at the end of the process they come out with a decision or a recommendation. Many times in the literature you have people talking about, oops, that's the wrong way, the big black box. What happens in the process? You have a guideline panel together going from the problem to making the decision and making the recommendation. And how do we move away from this kind of decision making? How do we create more transparency in considering all of the important issues that may affect a decision or recommendation? So just to look at the process flow from the World Health Organization for guideline development, there are 6 steps that they outline. One is to identify the questions. So they'll have a particular problem in the world, a priority issue, and then identifying the particular research questions or questions around which recommendations will be made. There's a process of retrieving the evidence from the globe. So this is where systematic reviews come in, with retrieving and assessing and synthesizing steps 2 and 3, all the available evidence to address and respond to that question. Following this, you have the discussion and formulation of the guideline process. You produce a guideline and disseminate, implement, and hopefully evaluate and plan to update. So for today, really, the focus is on the discussion and formulation section, because within each of these 6 areas, there's a whole process that needs to go into it. So in a nutshell, evidence to decision frameworks. So it's a framework with multiple components, and they provide an explicit and structured approach to decision making. They're there to enhance transparency. But transparency is, maybe we can strive towards absolute transparency, but there's so many complex processes that happen in people's thinking and minds when it comes to making decisions, that this framework is there to assist with transparency, but it doesn't prevent a guideline panel disagreeing on issues, making very important judgments, including the use of experts who may have specific content or context knowledge, but it allows a space for disagreements to be explored and built on. When you look at the main sections of an evidence to decision approach and the evidence to decision framework, it is broken into these three main sections. The question, which is where we detail and define what the PICO is, that is the population, intervention, control, and outcome for an effectiveness kind of question. What is the question we're asking? What perspective are we taking? And this is very important, although not the content of this webinar, but whether you're considering things from a population perspective, what's good for the masses, might be very different from the perspective of an individual. So for example, if there's an expensive treatment that may be easier to use, and as an individual, I know my insurance agency is going to cover that treatment, from an individual perspective, I may choose to use it. If, on the other hand, you're a group like a national ministry or the National Institute of Clinical Excellence in the UK, NICE, where they develop guidance on a population level, at that point, cost and cost effectiveness come into the question. So even if it's more convenient at an individual level, there might be a decision that considers the population needs. So the question is a very important area to consider. The next section of an evidence to decision approach, so you would capture all the information about a question. There's assessment of the evidence, so there's the research evidence, additional considerations, and capturing systematically the judgments of a guideline group. And following that, also capturing systematically the summary of the judgments, the type of recommendation, any justifications, and any other information that has come up around, do we need more research? Are there any implementation or contextual information? How are we going to monitor and evaluate this? Given the time available today, I'm going to focus mostly on this middle section, which is on the assessment and the criteria that take a person from considering the evidence to making a judgment. But I'll touch on the conclusion a little bit as well. So this is a question to you, and so this is not a rhetorical question, but I want to know from you if what do you think are the factors that should be considered by guideline panels in making a decision? So please write your message into the chat box. So what do you think is important when making a decision about resources? So thanks, Anel's added resources in there. Excellent. Context, yes, what's happening? Thanks, Christine. Priority. So priority, like what is the big issue? Evidence, great. And I guess evidence is a catch-all phrase. The staff available, we've got evidence coming up. Evidence, I guess what kind of evidence? Cost, feasibility, the level of evidence. Yes, not just the evidence, but can we trust the evidence maybe? Acceptability, right. So we can have the best recommendation, but if it's not actually acceptable, I think those are all really, really great points. So let's see what I've got here on my slide. Okay, so I've put some things in here in terms of ideas, and I think it reflects a lot of what you've all mentioned. I think there's some more that have come through. Quality, thanks, Martel. So looking at what I've put up here, maybe I can ask you all to draw again and say which one of these do you think is the most important one for making a decision in a guideline panel? Can you put a cross or a tick or a mark on the one that you think is the most important using your pens? Luckily, no one knows which color is which, so it's fairly anonymous for you to write wherever you want. Yeah, all great points. So I guess feasibility is coming up quite strongly here. as is efficacy. And I think this is would be a great conversation to have if we could all be chatting in a room, because safety, feasibility, cost, and equity, Jovita, thanks for sharing that. So feasibility, I guess if it's not feasible, should it happen? Should we even consider it? But I'll give you an example that comes to mind is, for example, a number of years ago, we did not have the antiretroviral tenofovir even registered in the country. And in effect, you could argue that we couldn't recommend tenofovir, even though it was known to be the best first-line agent antiretroviral for patients. And yet, if I'm not mistaken, we did include it, or some of our East African colleagues included it in guidelines because they knew it was coming. So even though the feasibility wasn't there in the moment, it was something to be, it was planned for when it did come through. These are all tricky issues. The other question I sometimes ask myself around efficacy is that if we find that something is efficacious, so let's say we look at efficacy, and if in the first place we see it doesn't work, should we even proceed with the process? I guess the other questions are what would be the alternative options, and these are all the difficult questions that a guideline panel would have to weigh up. And if you read through the literature around this, and if you participate in these processes, I guess you start to see that, when efficacy is very clear, for example, we know that it works, and relatively speaking, it's safe and it's cost effective, you're more likely to recommend something and make a strong recommendation for. When efficacy is kind of moderate, or the evidence is uncertain and safety is in question, even if it's the cheapest agent on the block, there'd be a question about whether you should be making a strong recommendation for something. So I'm going to clear the slide and see if I can navigate onwards. Okay, there's my note that came after. So the criteria for assessment in terms of making the decision, going from evidence to decisions, and I'm going to run through them as they appear on the framework. So I'm going to go one by one and I think it resonates exactly with the things that everyone has mentioned here. First is the problem. How big is this problem? Is this problem a priority? Do we need to tackle this issue now? What are the desirable effects? How efficacious or effective is this intervention? So does it work really? How substantial are the desirable anticipated effects? And the evidence to decision framework that GRADE uses and that some of the WHO panels use include this long list of questions. So I'm going to run through them. Undesirable effects. How substantial are the undesirable anticipated effects? So that might be harm or safety issues. And then, very importantly, for those of us that are researchers and we're tackling this issue of certainty of the evidence or the quality of the evidence, can we trust whether it's the truth? What is the overall certainty of the evidence of effects? And then the balance of effects. And this is where the guideline panel looks at the desirable, the undesirable, and how certain they are, and have to make a call. Does the balance between desirable and undesirable effects favor the intervention or the comparison, or is it hard to tell where it sits? Is it sitting somewhere in the middle? Because based on that, it will impact decisions further down the line. Increasingly, we recognize it's not just about the evidence of efficacy, it's about values, and I could see that people were mentioning equity and other things on the previous slide. So yes, so is there important uncertainty about, or variability in how much people value the main outcomes? And who are the people? So this might be patients themselves, this might be the people who have to administer the new intervention, and it might be society as a whole. So looking at values, complex stuff. Resource requirements, so there are a few elements of this. How large are the resource requirements and costs? So it's not just about the medicine cost necessarily. It could be about broader issues of staffing, training, and other issues that are required. What is the certainty of evidence of required resources? So how sure are we about the cost of things? And I don't know if any of you have worked with economic evidence, and I'm learning a little bit that it's quite difficult to do detailed economic analyses without proper costing data. And in South Africa, certainly we we don't always have all that costing data available. So we do the best kind of modeling that's possible, and I'd be open to any input from others at the end of this session. Cost effectiveness. So ideally, we should be looking at cost effectiveness. Does it favor the intervention or the comparison? So moving away from costs and resource requirements, there's equity. What would be the impact on the health equity? So this is a criteria that's considered separately amongst all of the different criteria that I'm listing off here. But if you read around equity, it's also the way that you pose the question, the PICO, the population and the vulnerable populations that you consider is another area in which equity could be considered. So equity can be considered in all of these areas and with the intention that there shouldn't be an increase in equity when a new recommendation is put forward. Acceptability, is the intervention acceptable to key stakeholders? Feasibility, and a lot of people thought this was particularly important, and I agree. Is it feasible to put this into place? If the medicine requires a refrigerator and you now want to distribute it into rural areas, how feasible is that? What are the other costs and resource requirements with getting something out there? So it's very useful that all of these criteria are considered in making the decision, because then they are captured and considered in the guideline process. So again, we're trying to move away from this type of decision making where we don't know how the decision or recommendation was come about. We're moving away from the GOBSAT approach where a bunch of people sit around the table. It's not always the good old boys anymore. It's sometimes good old girls, and we sit around and make a decision and nobody knows how or why. So I'm hoping that this slide is clear enough for everyone to see. But this is also a further description of the different sections of an evidence to decision framework. And that is, you have your problems and the options. These are the criteria that we've just looked through: benefits and harms, values and balance of effects, resource required, cost effectiveness, equity, acceptability, feasibility. And for each one of these factors, we consider the research evidence. In addition to research evidence, there might be additional considerations, contextual information that will maybe more important or override some of the evidence, or maybe have to replace the fact because there isn't enough evidence, and after which the judgment is made, and this is the conclusion section of the evidence to decision framework. Let me unpack this a little bit more in terms of ensuring transparency. So for each of these areas, I mentioned that we need to consider the actual evidence base for this. Now, many of myself, or particularly me, I've been mostly involved in efficacy or effectiveness studies and particularly systematic reviews, but increasingly it's all of the factors that require some kind of evidence base. So for benefits and harms and, does it work and what are the safety issues, effectiveness studies might be the most appropriate and generally are, and a systematic review of trials is generally the gold, what we're aiming for. But in terms of values, there'll be other ways of capturing this, including utility studies, but more so kind of qualitative studies, resource use. You can do things like, as people describe, back of the envelope kind of just, measure out how much does the medicine cost or the intervention cost, but it doesn't take into account all of the other resources required. So then you need modeling or economic analyses. And further from that, the equity, acceptability, feasibility, these also increasingly require evidence to underpin them. It's not just a discussion around the table. And we're seeing more and more qualitative reviews of these very challenging issues coming to the fore. And an excellent example from one of the colleagues that shared some slides is from Simon Lewin in the Maternal and Child Health Guideline Development at WHO, where they are working particularly on qualitative reviews that inform these issues around difficult issues. And you can imagine with maternal child health, issues around termination of pregnancy, or lay health workers delivering treatments that are generally provided by other levels of staff, and is it acceptable and feasible? And by looking at these systematically in systematic reviews of the evidence, it's hopefully giving a broader picture than we might perceive if we were just sitting around the table having a conversation about it. Yeah. So, as I mentioned, in addition to those criteria and looking at the evidence, preferably from systematic reviews of the evidence base for the relevant studies, there might be additional considerations. And then the panel's judgment. And so going through all of this process is ideally trying to create clarity in how the judgments are made. So I want to just share this diagram of where evidence to decision frameworks might fit into the guideline process, just to put another graphic edge onto it. So if you imagine that we are all sitting on the guideline development group, there's a process of conducting a systematic review, and then there's guideline development. So these are quite closely linked, but it's generally not the guideline development group that is doing the systematic review. But what the guideline development group will give input into is formulating the question, because the guideline development group should have relevant stakeholders, including those that may be using the guideline and those that may be affected by the guideline decisions, such as consumer representatives. And they should give input into what is the question and what are the outcomes that are particularly important for making decisions. So we rate they would be involved in rating the importance of the different outcomes. So, you know, if an outcome is not as important, that might not be the deciding factor. You want to look at the critical and important outcomes. And then the systematic review, the methodology team will extract the outcomes across all the studies that they find and develop these summary of findings tables or some kind of summary tables to present the evidence in a systematic way. And within GRADE, so GRADE crosses both systematic reviews and guideline development. And I guess that's a little bit of what I wanted to show, was that you can rate the quality of the evidence. So evidence, say it's an evidence of effectiveness about a trial, the evidence starts high, but you may rate it down because of the methodological quality of the study, risk of bias, because of inconsistency or, you know, heterogeneity, studies going in, the results going in different directions. Indirectness, because the question doesn't directly apply to your question. Imprecision, so we generally, as researchers, we would know imprecision is around the kind of the sample size or the number of events that are occurring, and the issue of publication bias. But you can also grade things up. So studies that are not trials, you could grade them up for various reasons. And so this is all the information that the methodologists would be providing and feeding back to the guideline group. Guideline group would review the summary of findings table and have to consider the overall quality of the evidence for the specific question that they're looking at. And this is where the evidence to decision framework comes in. The guideline development group needs to make the recommendation either for or against. So that's the direction of the recommendation. And they need to, increasingly we recognize that they need to inform what the strength of the recommendation is. Is it a strong recommendation or a conditional one? And I'll come back to that. And we consider all of these elements: quality of the evidence, the balance of benefits and harms, values and preferences, resource utilization, equity and human rights, acceptability and feasibility. So they all fit in to finally inform the guideline, which will have recommendations. And just as a small plug around formulating the recommendations, so for example, if it was a strong recommendation, the panel might say, we recommend using. If it was a conditional recommendation, the panel might say, we suggest using. And the same could be said, that's for a recommendation. There might be against a recommendation in terms of the direction and strength. I don't know, Solange, if I should pause there or if I can just carry on and take questions towards the end while I'm in the flow. But if someone drops Solange a line, you're welcome to. So in terms of making the recommendation, as I've just gone over, so part of the evidence to decision framework will include this section, which is the type of recommendation. It's either for or against the option. You might have I got my, oh, there it is. My strong recommendation against the option, conditional recommendation against the option, conditional recommendation, either the option or the comparison, so it's kind of sitting in the middle, or you may have a recommendation for or a strong recommendation for. What are the implications of a weak or conditional recommendation? I guess it was called a weak recommendation. Guideline panels and practitioners and people just generally don't like the word weak, so they prefer the word conditional. But basically it's saying if there's a conditional recommendation for policymakers, it means there's a need for substantial debate and involvement of stakeholders in making that recommendation. For patients, the majority of people in this situation might want the recommended course of action, but many would not. And from a clinician's point of view, you should be more prepared to help patients and have a conversation about the decision that is based on their own values, part of shared decision making. So that's the implications of a conditional recommendation. For a strong recommendation for policymakers, it's a bit easier. If there's strong evidence, the intervention's not too expensive, the recommendation can usually be adapted as a policy in most situations. For patients, most people in the situation would want the recommended course of action and only a small number would not. And for clinicians, you would generally be recommending most patients should receive the recommended course of action. So this is what we mean by a strong and weak or conditional recommendation, and it's for or against. So finally, maybe I should have put this up front. This is one of the grade evidence to decision framework. Some groups work with it in a Word document. So I have an example here, which is a Word document from the DECIDE group, where they consider these different aspects. So there's the criteria here, the quality of the evidence, the balance of benefits and harms, resources, inequalities, implementation, and feasibility. So you can see different groups might actually amend or adapt the framework according to the questions that they feel their guideline group wants to tackle or feels relevant in that situation. The one I presented a slide with lots of different domains. That's the standard grade evidence to decision framework. It has many questions, and then in addition, it has kind of the way that they ask the question in terms of deciding, making a decision, a yes/no decision. Is it high, moderate, low? So there's more behind how we make these decisions. But in essence, you have a criteria, the decision by the panel, and you might have extra comments, or this is the additional considerations that a guideline panel might want to add here. So you might include information about the evidence, but you might also include additional considerations. I wonder if this will work. I'm going to try and open up an electronic, it's called an interactive evidence to decision framework that Grade Pro and the Epistemonicus have developed. And this is from one of the readings that I'll share on the last slide. Okay. Solange, can you see that? Is it all fine?
Yes, I can see it.
Okay. So this is a particular example, and we won't go into the clinical details about it, but it's about patients who have an irregular heart rhythm and at a risk of stroke, and they're currently taking a blood thinner called warfarin, and there's the question of whether they should switch to the new anticoagulant dabigatran, which is more expensive but more convenient. And so in the interactive evidence to decision framework, a person can register and log in. Your whole guideline group can actually register and log in, and you can then have all the background information. So remember I said there were different sections. Well, here I mentioned 3 sections, but there's basically a background, which includes the question in more detail, and anything that you want to give in terms of the perspective of the guideline panel. Are you thinking of a population or an individual? What is the setting? Is this for a country? Is that for a district? Is it for a hospital? Who are the decision makers? You can also, and then there's a bunch of background information in here. Within this interactive evidence to decision framework, if you do have a guideline panel working together, there's, if I'm not mistaken, I haven't checked this one specifically, but there's a process for doing automated conflict of interest management. So you can There's a conflict of interest form that each of the panelists will be emailed and they will need to complete. That can be adapted for different panels. So in addition, after the background, you need to make an assessment. And all of those questions that we covered earlier was around the problem, desirable, undesirable effects, certainty of the evidence, etc., etc. And so it goes through all of them. If I open up, for example, desirable effects, where we're interested in the efficacy, so there's the research evidence, and you can actually see the summary of findings table, but I won't go in there. And then there's a question: what is your decision about how substantial are the desirable effects? You don't know, you think it varies, or they're large. And if you can imagine, a whole panel can be voting on this and then discussing the conclusions at the end. So that's desirable effects. Let's see if there's another one I could look at. Values. So there might be research evidence around that. They refer you to a paper here. Additional considerations. There's nothing in here, but they direct you to a question and a decision. The issue of equity, for example. So what would be the impact on health equity? So it's quite interesting, because if you think of warfarin, it's a blood thinner that requires you to go in for regular blood tests. The new drug doesn't require regular routine monitoring. And they look at the research evidence. There's nothing to say how will this impact health equity, but they have written about additional considerations. So this new drug might reduce inequities despite the cost, because there might be people out there who can't actually access this routine testing. And for someone who's living in a rural area, for example, and access to health services is reduced, actually this more expensive agent might be a better option than using a drug that's not as effective, such as aspirin. And so the group would all have this conversation and make a decision. I mentioned that the group could be voting. Generally speaking, guideline groups like to work with a consensus approach, but this captures people's considerations and views separately. So this is the assessment section, and then it would give you information on a decision. You would write more about the justification for the decision, implementation considerations, and how the guideline group considered monitoring and evaluation should happen. And the interesting thing with these online processes is basically from there, you can go to kind of automatically publish a guideline. So there's a lot that's happening in the electronic space that isn't hitting our guideline groups yet, but it is something that will come our way in time to come. So let me see if I can go back to my slide presentation. Yes. Okay. So, in just kind of summing up and making sense of all of this, evidence is essential to inform decisions, but it's not sufficient, and judgment is required. And I think no one wants to run away from the fact that the experts sitting around a guideline panel are the people that need to make the judgment. What we're trying to do is make sure that it's done in a more transparent way as much as possible, systematic and transparent. So, grade evidence to decision frameworks can help guideline panels and decision makers move from evidence to recommendation by informing judgments about pros and cons of each option. So you look at it systematically, consider different important factors that determine a decision, provide a concise summary of the best available evidence to inform judgments, and you help structure a discussion and identify reasons for disagreements in a systematic way, without missing important issues such as equity or feasibility. And making the basis for the decisions, whatever it may be, even though it may be different in South Africa than it might be in Malawi, but it makes the basis for the decision transparent and adaptable for different target audiences. So I have a question to the audience about how you can see yourself using this framework. And I wonder, Solange, if we can now pause for a conversation for a few minutes on any questions that people may have about this before we finalize, before we close up, but also if people have experience, maybe have the opportunity to share that via the comment boxes or anywhere else.
Yes, Tamara, that sounds good. So if anyone wishes to say something or ask a question or share their experience, feel free to unmute yourself and speak, or just add it to the chat box.
So I appreciate this isn't the easiest forum to have a conversation or discussion, and maybe I hopefully have shared a fair amount of food for thought. I'll share let's check if there's someone who wants to ask. No. I'll share my email address on the final slide so that if anyone wants to contact me or share other experiences or explore, there's a lot happening in this space around even sharing evidence summaries, sharing these frameworks between different guideline groups. And wouldn't it be marvelous if we could in the region be sharing resources, because we have such limited resources. So there could be groups doing systematic reviews, but we could also be considering the contextual issues that are particularly relevant for us in completing these frameworks, but we could be sharing them. How do we do that? So hopefully some of you have got the answers to all of these difficult questions. So
there's a question.
So some questions are coming. Yeah?
So there's a question from Dr. Wafeo on, is it possible for a practitioner to create a guideline group in his hospital?
Yeah, I don't see why not. If there's a particular policy issue, and perhaps it's worth, so for example, I think at many times there are hospital level guidelines. So, and it might consider more implementation issues. So hand washing is an example. So we all know hand washing is good, but how that guideline can be made clear to people in the hospital or implemented in a more practical way that makes sense. So certainly a guideline group could be convened and could use freely available software like I've demonstrated.
And then there's a comment from Tando who says that he's noticed that certain guidelines depend on who's sitting on the panel and what their preference is.
Absolutely. So I guess that is the whole point of bringing a bit of balance to the conversation, because we need those experts with their opinions and their experience at the table, but we're trying to move away from the gobsat approach, which is the good old boys sitting at the table making the decisions based on their preferences, or as some of us who have experience of this, is people who feel very strongly and passionately and sometimes loudly about things are taken notice of more than the others. And so with the WHO, who in 2007 there was an evaluation of the WHO guidelines that showed that they weren't doing the best job because they were very expert opinion driven. And they then put in place a guideline review committee. They put in place these grade evidence to decision frameworks. They ensured that every guideline panel had better representation, not only the content experts, but also the methodologists, the people doing the systematic reviews, so that there's a balance around the table of people who can bring different expertise, and particularly the inclusion of the methodologist, who's someone who can take people through the evidence to decision framework process and make sure that it's not just personal opinions, although that might be necessary if the evidence is very weak, where it'll be opinions that'll make the decision. But having that in a transparent way, I hope you all can see the benefit of having this framework, whether it be in a Word document or a PDF or online, to ensure that we move in the direction of transparency as best as possible, despite the fact that we will be surrounded by different opinions wherever we go. So it's a real leveler, I think, bringing level and balance to difficult conversations and different decisions that people make. Thanks, Tando, for your comment.
Tamara, there's another one from Hando around why include weak recommendations, because they can be confusing if people want to use to do something when you have a weak recommendation in a guideline.
Yeah, I think that would be a great conversation to have around the weak recommendations. But I think I think increasingly we as practitioners and we as decision makers need to be more transparent and clear about the fact that we don't always have all the evidence, and that the weak recommendations means that there needs to be a conversation between practitioner and patient, for example, around what will be best in that circumstance for that person, because the evidence isn't strong enough to say that most people would want that intervention. So it's really pushing us to be comfortable with the fact that we don't have all the answers. And it's quite difficult because many of us would have been trained in a very patriarchal approach to medicine, which is the doctor knows best. And many of our patients turn to us to ask, make that decision for us. But increasingly, in the face of uncertain evidence, that honesty about around shared decision making is what we need to try and tackle. I think we're not there yet, but it would be interesting to get there.
And then there's a comment from Kim around that most times we're doing systematic reviews without guideline development group input, and how do we get their inputs into the review questions in advance so that we can make sure that systematic reviews are used.
Yeah, I think that's a great point. I think it's pretty important that they are part of it. Usually there's a bit of behind the scenes work with WHO where they will be engaging the guideline panels on the PICOs. And only once the PICOs have been formulated, they would then kind of farm those PICOs out or commission reviews. So the input is really on the outcomes of interest often, but it is nice when you have the opportunity to be not only just the service provider and providing a systematic review, but actually be part of the process. And maybe it's something to think about asking for. Yeah. Good point, Kim. So it should be the methodologist, the researchers, and the guideline panel should be working closely. I'm going to move on. So just in wrapping up, I've got some useful resources here, some access to the free online software, some great articles that really unpacks it in the simplest of terms. So I encourage all of you to get that, and that'll be available. Solange will circulate it, or we'll circulate it after the event. I also want to make a plug for the Cochrane Africa Indaba, African Cochrane Indaba, which is having 25th to the 26th of March 2019. Cochrane Africa is a collaboration between West Africa, Francophone Africa, and Southern Eastern Africa, each with different leads and activities happening. But we're very exciting to be hosting this. South Africa will be hosting the March event. So please click on the abstracts, click on the page, submit abstracts, come and attend the meeting. I think it's going to be great. We will have, I'm hoping, crossing fingers, I hope I'm not speaking too soon, but we'll hopefully have colleagues such as Holger Schünemann or others that are very involved with guidelines, involved with knowledge translation. And the whole impetus of this meeting is around evidence-informed policy making and knowledge translation. I think there's going to be great stuff on. So stay in touch and watch that space. So that was my little plug for our event. So just to wrap up and say thanks to everyone for your time. It's been great to do my first webinar with you all. And yeah, look forward to staying in touch about this topic.
Thank you so much, Tamara. And thanks everyone for attending. Bye-bye.
Thank you for hosting us. Bye-bye.
Bye. Is that Villian?
Thank you, Tamara.
Hi, bye. It's nice to see so many of your names on there. I wish